Hi guys. Thank you for all taking the time to join us today. I'm Mariam and I'm part of the core team. Some of you have seen me in the past webinar. Before we start, just basically put your name and where you're from in the chat and just let us know where you're from so that we can see where in the world we're all from. And just one side note, the Gofundme link that was spoken about in the video is going to go in the chat now for anyone who wants to donate as well. Right, guys, so today we're really lucky to have Dr. Tadros with us. Just a bit of a short introduction. Dr. Tadros is a specialist endodontist. He received his BDS degree from the University of Alexandria in Egypt. He then moved to the United States, where he received his Doctorate of Dental Surgery degree from the University of Washington. After this, he earned his endodontic certificate at Boston University, and he serves as a captain in the US Army Reserve Dental Corps. He's actually the first and only board-certified endodontist in Hudson and Nashua, and he was an associate clinical professor at Harvard University, so there's not much he's not done. He's also worked at a children's hospital where he provides root canal treatment for special needs children. So if anyone has any questions during the talk or anything like that, just put them in the chat box and then they'll be answered at the end. But for now, over to you, Dr. Tadros.
Thank you, Miriam. I'm going to start sharing my screen right now. All right. So good afternoon, good evening, or good morning for some others. My name is Tadros, and I'll be talking to you today about cracked teeth and diagnosis, cracking the code of treating cracked teeth. The outline of this presentation would be some introduction about the subject. We want to define cracked teeth and crack types. We want to understand the difference between the signs and symptoms of cracked teeth. Also, to be able to learn how to detect and confirm cracks in a stepwise system. And eventually, like, we were just going to go through a classification of longitudinal tooth fracture. Just a background about me, briefly, like Miriam did, I did my BDS degree in Alexandria, Egypt, and then I moved to the United States, did my DDS degree in University of Washington, Seattle, and I did my endo residency at Boston University. I'm currently an Army officer in the United States Army Reserve. And in 2019, I received my diploma status from the American Board of Endodontics. This is just a few pictures of my office. I own and I practice in Hudson Endodontics in Hudson, New Hampshire, which is a town on the border between Massachusetts and New Hampshire. These are a few pictures of the stuff we have: CBCT, sterilization, and one of the operatories we have. So moving forward to speak about the subject today, we were talking about cracked teeth, and many of my colleagues in this presentation, there have definitely, if they're practicing for a while, I'm sure like you've seen quite amount of cracked teeth or some symptoms confused to cracked teeth. I wanted to start this presentation by showing this article that was published in the New York Times magazine that was back last month. And this article was actually written by a dentist who practices in New York City. And he was basically talking about that since he reopened his practice after, like the surge of the pandemic, he has been seeing a big surge of cracked teeth in his office, almost on a daily basis. And he used the term the epidemic of crack. With that happening, it definitely put a lot of load on dentists to be able to identify, understand cracked teeth and the reasons and how to treat it, and when to extract, when to treat, when to cap, all these stuff, because we've been seeing this more and more. And as an endodontist, there is no one single day I don't see at least one or two cracked teeth that need either root canal or need extraction. So, like I said, we are seeing more cracked teeth these days than the past years. Obviously, nowadays, is becoming more and more relevant because of the stress due to COVID. Some psychologists, they started using the coronaphobia, like the fear of coronavirus and all the impact that it's causing to people from a health standpoint, from an economic point of view, from a social point of view. All these stuff are putting a lot of load, a lot of stress on us. And that's basically is a collective of affecting our overall mental health well-being. Stress signs are a lot, but many of them like lead to clenching, grinding. That definitely can damage teeth. The goal of this review is, like I said, to help general dentists to treatment plan, diagnose, understand cracked teeth, to have the proper tool to have a diagnosis and treatment, to understand how to deal with this, and also the ability to determine the difference or the extent of any longitudinal fracture, and when should you only put a crown, when you should need a root canal, or when you have this tooth extracted. This all depends on the location and the extent of the fracture. Cracks present in teeth are only findings. There is no, it's not a diagnosis. You can't say, oh, the diagnosis of this tooth is cracked tooth. So it's a sign. It's something that you see on teeth, and it can cause pulpal or periapical problems, and that's when you build your diagnosis, and that's how you plan your treatments. With this consideration, many teeth with cracks can actually be saved. The most important part, again, is to identify, classify those cracks, understand the sign and symptoms of each one of them, and to detect the crack as early as possible to be able to treat it as well. Because if you leave it for too long, it might be too late to save that tooth. As an endodontist, my main goal is to save teeth. So to move forward from that, we're going to be talking about defining crack type. Like I said, location, direction, and extent of the crack is used to help doing this identification. 5 types of longitudinal fracture are crazed line, split tooth, fracture cusp, vertical root fracture, and cracked tooth. Only after these fractures have been defined and characterized, you can have an understanding, and you can basically direct your treatment plan, whether you can save that tooth or not. Crazed lines are only, and we will be talking further about that, of course. Crazed lines only affect enamel. You only see them enamel, while like fracture cusp or cracked teeth or split teeth, they begin in the occlusal and extend apically, and they affect enamel, dentin, and possibly the pulp, depend how far they extend. Vertical root fracture begins in the root and all types of those, except for the crisp line, they definitely present or exist on posterior teeth. Unlike broken bone, the fracture in a cracked teeth never heal. If you have a fractured bone, we all know that you can treat that, the bone can regrow again, but our teeth doesn't have this capacity, doesn't have this option. We cannot grow teeth again, at least at this point. Once fracture happens, it happens. So just to clarify a few things, I've seen it over the course of years, and many of my colleagues could be confused by cracked teeth. We have all heard the name cracked tooth syndrome. And honestly, a few years ago, the American Institute of Endodontists took off this term completely. Like, there's nothing called cracked tooth syndrome, it's just cracked tooth. And the reason is if you go by what was there before, syndrome is characterized by acute pain, mastication, tough foods, or sharp, brief of pain was cold. These findings are also related to cusp fracture. However, cracked teeth may present with a variety of symptoms, and it's really hard to have like a specific sign. This is a syndrome. If you have 1, 2, 3 sign, then this is a syndrome. Because like sometimes they come separately. Again, those symptoms could range from a slight pain to severe spontaneous pain. It could be with pulp necrosis, or it could be with irreversible pulpitis, or sometimes with apical periodontitis as well. So that's why we stopped using the word or the term cracked tooth syndrome. It's just cracked tooth. Even with sometimes, like you see acute apical abscess, with or without swelling, draining sinus tract, this all could be present if the pulp has undergone necrosis. Sometimes fracture can extend and expose the pulp, severe pulp, or periapical pastosis could be even present. This explains lots of variation between sinus symptoms, and therefore it should not be termed as a syndrome. So moving forward with presentation right now, we're going to be talking about the steps, the obvious and the obscure, the steps of cracked teeth detection and confirmation. And to do that, we have to follow particular steps. If crack is suspected, several steps you have to follow. First, dental history. Sit, listen to the patient, listen to the chief complaint, talk with the patient, and see what are the symptoms and what led him to your chair with this particular complaint. Periodontal probing is very important. Subjective examination, you do the clinical examination, check the gingiva, do your due diligence on doing your clinical exam. X-rays, radiographs is very important. Like I said, visual examination. And then if you need to remove a restoration, remove a restoration. If you need to do some tactile examination, do it. This is like on the right, you can see like an example here. This is a case where like the patient has an occlusal filling. You remove the occlusal filling and I can see that there is a problem. There's a crack right there. On the other hand, you have this patient who just come in with a version tooth, no filling, nothing, and you can see a clear crack in there. Again, staining. Using methylene blue stains sometimes could be very important. And put a picture right there. Sometimes you need to do a periapical test, transillumination, to be able to see the crack. And I'll talk further about this in relation to different type of cracks. Biting test, wedging forces, vitality test, which is something we do on a daily basis, on a regular basis in endodontics. And finally, surgical assessment. Sometimes you need to do a surgical exposure to confirm a crack, and those are cases that I've done before, and I will go through an example as we move forward. Now, classification of longitudinal tooth fracture. Like I said, crazed lines, fracture cusp, cracked teeth, split tooth, and vertical root fracture. Those are the 5 main recognized categories of cracked teeth. Those agreed on, and the research supported their signs and the symptoms. And this is in the last classification made by the American Association of Endodontists. So I'm going to start with crazed line. Craze line, everybody or everyone as we grow, we form craze lines. We see them mostly in adult teeth. Rarely really see them on in posterior teeth, craze line usually appears on marginal ridges. They appear on buccal or lingual surfaces, as we see on the picture on the top right side. On the other hand, in anterior teeth, like we see them as a long vertical craze line, as you can see in the bottom right. They only affect enamel. They don't extend to dentin. Sometimes, and many of the times, actually, they don't cause any pain. Sometimes the concern the patient might be having is just appearance. And again, it depends on the patient need. You can basically treat those if there is a severe cosmetic or aesthetic reason concern of the patient to address that. But they're usually not involved in a dentin, or they don't really extend to the pulp, and they don't have any symptoms or pain. How to diagnose them? Transillumination is usually like the best way to do it. If the tooth is cracked, the light will be blocked, and you're only like going to see a segment of the tooth to be lighting up. If the tooth has a craze line, the entire tooth will light up, and that's what we see in an example here. You can see that the whole tooth is lighting up. This is a craze line example on an anterior tooth, and you can see that very clearly. So transillumination is your best tool to diagnose if it's a crack or if it is a craze line. Now I'm going to move to fracture cusp. Fracture cusp is either complete or incomplete. Usually start in the crown of the tooth, and sometimes they extend subgingially. Usually they are directed both mesodistally or buccolingually as well. So, and you can see here in the diagram I put here, this is an example of a fracture cusp, and it's usually coronally in origin. Fracture also usually involve at least two aspects of the cusp. Sometimes it crosses the marginal ridge, and they can be extending into a buccal or lingual groove. The fracture might extend to a cervical third of the crown. Really depends how bad the situation is. Treatment planning. Again, it depends on how much lifted to structure. The first thing you do is you remove the loose part, and then you can assess what can be done. You can either like put like a direct restoration, composite, something like this, or sometimes like you need to put a crown only to cover the crack margins. If the crack, or if you feel that the root canal is needed, then you might need to do root canal or pulp therapy if the crack is affecting the pulp chamber, or if the patient becomes symptomatic with some irreversible pulpitis symptoms. Now, moving forward to crack teeth. Crack teeth is usually like incomplete. According to the definition in the AE glossary, it's an incomplete fracture. Again, starting the crown, extending subgingivally, and also directed mesodistally. The fracture might be extending into marginal ridge or through the proximal surfaces. The fracture is also located in the crown portion of the tooth only, or sometimes may extend to the proximal root, but it doesn't start in the root. It starts usually in the crown portion. Cracked teeth are described as incomplete green stick fracture. Occlusally, the crack is usually more centered and apical than a crack cusp. Basically, what you see is worse than that. Probably the crack is deeper than how you see it clinically. And this is an example here on the right side of tooth that looks cracked, but it's actually like deeper than how it looks. And it's usually extended apically. How to diagnose that? Wedging. Wedging, so like use like a wedge to test it, and you had the patient bite on it, and you can see how it goes from there. It will help you to differentiate between cracked or fractured cusp or split tooth. If there is no movement, then it's a cracked tooth. If there is movement, or if you have like a break off or a slight pressure with no further mobility, then it is a fractured cusp. A split tooth, you will see with the wedging that the mobile segment will probably like move, and you can see some mobility when that happens, and that's when you have a split tooth. So wedging is a very good tool to help identifying the problem here and basically see how to differentiate between different types. How do you treat that? Again, it depends on the location and the extent of the crack. Performing root canal also might be needed if you have a periapical or a pulpal diagnosis. You have to have a diagnosis. You can't treat if you don't have a diagnosis. So if the patient is, for example, if the patient is symptomatic and you do your test, you have to have a pulpal diagnosis and you have a periapical diagnosis. And that way, you can determine, okay, root canal is needed or not. And then based on that, you can build your treatment plan. So moving forward, I'm going to use an example here. Sometimes this crack could be going to the cavity floor, or it could be just on the proximal external surface. Depending on the location, we can treat it in a different way. So I'm going to use the example of the cavity floor. And in this picture here, patient has had a cracked teeth symptoms. So we decided to go and remove a silver filling or an amalgam filling that he had back then. And we can see the crack clearly right now in the area where the cavity is. Patient was having a symptomatic irreversible pulpitis, so we decided to move forward with the root canal. And that's when we were able to do initiation of an axis. There's no problem with doing your axis this way. And it's not going to affect any problem with the tooth itself. And you can see that the crack, how far it will extend to the pulp chamber. And you can make a determination of the extent of this crack as you go with your root canal treatment. But on the other hand, if you have it on a proximal surface, it gets a little bit tricky. Because if you can see here an example here in the picture I have, if you keep chasing this crack and moving forward to the proximal area, you might weaken the tooth, and the tooth itself might not become restorable. So you need to be very careful when you are accessing those teeth. And as you try to identify how far this crack extends. You need more information, of course, about that, and you can make a decision whether the tooth can be restored or not. It depends on how far it goes. And in this particular case, as you can see, the crack is extending all the way, and it's very deep and out there, and it's going all the way to the canal. And in this case also, there was some probing, so patient options were not that great, and we can explain to the patient the options and how we can go from there in terms of what we can do. You can see also in this picture, I use a stain. It really helped me identifying how this crack goes. Using the microscopes definitely helps. So that's a very good tool to use as an endodontist. And that's why it really helped us to make a proper determination whether the tooth can be saved or not. Prognosis. Prognosis of cracked teeth is usually questionable because mainly for that reason, we don't know how far this can go. And we cannot also determine if it's gonna stop on where it is or if it's gonna get worse with time. And it might grow with time. So you have to explain this to the patient, and you have to put the patient expectation within normal or within reality. So when you have all these options, you will be able to make the proper call whether you can save the tooth or not based on also the information that you lay to the patient. But definitely overall prognosis for these kind of cases is usually questionable. Now moving to another subject, split tooth. It's a complete fracture. It's initiated in the crown and it's extended subgingivally. Usually it's mesiodistally, and usually it's both marginal ridges of the tooth and the proximal surfaces are involved. Split tooth is the evolution or the end result of any cracked tooth. If you leave the tooth without any treatment, you're gonna get a split tooth eventually. So what starts as cracked tooth can become a split tooth as you go from there. And it can extend to all the areas basically in the tooth. And as we can see here in the example of the picture I have right there. And yeah, actually going back to this picture, this particular patient, she had a crack in their tooth. She came in, we spoke with her, and we basically recommended that she go and get a crown, because at this point there was no pulpal passosis. So we recommended to get a crown in that tooth. Patient waited for, I would say, like almost a year, came back again, and as you can see, the end result, complete crack here, split with perio involvement, and also back then, and when she came in, there was a pulpal, and there was also periodontal symptoms. So tooth had to be extracted. Split teeth can never be saved intact. You know, once the split happens, it happens. And once it extends apically, or depending how far it goes apically, we can determine whether it can be, whether the prognosis is acceptable or not, or is favorable or not. If the fracture is severe or going deep apically, then the tooth has to be extracted. If the fracture shears to the root or not too far apically, middle to the third or like cervical third of the root, maybe we can like remove the smaller segment, and if we can save it, it could be doable. There is also a good possibility that like this small segment can be removed, and we can save the tooth with a crown that can extend it a little bit deeper and protect this crack margin. Now, vertical root fracture, which is, in my opinion, one of the very frustrating type of cracks because of how difficult we can find it and how difficult to diagnose that and how difficult for this even to be detected on radiograph. It's a complete or incomplete fracture. Usually it starts at the root and any level, and it usually goes in a buccal lingually. That's why it's really hard to see it. And if you see it on the x-ray, then it's really, really deep. The fracture is usually like located on the root portion of a tooth, and it extended coronally toward the cervical attachment. This is an x-ray here. You can see this is a very classic view of the vertical root fracture. We were very lucky in this picture because like we can actually see everything clearly. Like there was no even need for any type of radiograph except for a regular periapical radiograph, and we can see clearly what's the problem here. Diagnostic clues: patient with vertical root fracture usually they come with minimal signs. They're not really in severe pain or severe pulpal pain. Usually it goes unnoticed for a while, and then patient, or it can be like detected on a routine exam and a hygiene exam. You take an x-ray and you see something that looks off, and the patient is completely asymptomatic. Sometimes it's difficult to diagnose it because they mimic other condition. Vertical root fracture also may be similar to perio disease. It might be even look like, oh, maybe it's a failed root canal. These cases often result, it's probably like better if you like refer it to an endodontist or a periodontist to evaluate and tell you basically is the perio problem, is an endo problem, it is a root fracture, so you can like treat it properly. All vertical root fracture happen in teeth with root canal. You will rarely see a tooth without a root canal that has a vertical root fracture. Mostly like you see different type of cracks in those teeth, but vertical root fracture, we see it a lot in teeth with vertical root fracture. Those clues are usually like a sinus tract, a narrow pocket, deep pocket basically, and you can like while you're probing, you can just see like how it drops in one particular spot. It could be, like I said, with a tooth with a root canal. Sometimes it's a post or no post, and it's considered. And all these symptoms basically are like considered. Those are the main clues for diagnosing a vertical root fracture. Recent study found that a vertical root fracture is usually occurred with a tooth with a root canal if there was a crack to begin with, or if there was something to begin with, and it just like got worse. So that's why it's really hard to predict how these cracked teeth will behave. But to answer the question, does root canal cause fracture or vertical root fracture? The answer is no, unless this tooth was compromised to begin with, or unless this tooth had or had an existing crack to begin with. And that's how things get worse with time. So vertical root fracture, the only predictable of treatment of this disease is extraction. There has been some studies, trial to see options of saving this disease, but they're all not really conclusive. We cannot save those teeth. Extraction is the only way. If you want to go the extra route, using or doing procedure like root resection or hemisection is an option. Like nowadays, with the technology we have on implant is a more predictable option. So in those teeth, in those cases, really like depend on the patient preference, of course, you can just recommend the extraction and implant after that. Prevention. Because of the causes of the vertical root fracture as well known, prevention is not there. The recommendation, if you are an endodontist or if you are a general dentist that perform root canal therapy, you have to avoid using excessive or like removing excessive dentin in there. In modern endodontics right now, we rarely use stainless steel or instruments like gates, Glidden, or piezo reamers, or all these tools are very well known that they're gonna cause lots of unnecessary removal of intraradicular dentin, and they're gonna cause internal wedging as well. Compaction, you know, like if you are not comfortable with doing the obturation, do not press hard, like do not go deep and push inside those teeth, but all this create wedging forces, and you have to be able to control the forces you apply during compaction of root canal filling material. Placing the post, you have to pick the right post for the case. You know, you can't use serrated, bulky posts because they cause fracture. So, and I remember like there was one prosthodontist friend of mine once said, before you think of placing the post, you have to say, does the core hold the post or the post hold the core? And based on that, you can find whether you really like need to put a post or not. Whether to put a post or not, this is really subjective to also opinion. We can definitely talk further on that in the future, but using the post when only needed is recommended, not on a regular basis, because they do cause lots of internal stresses on the root of the tooth. I'm going to be talking also right now about the use of CBCT of cracked teeth on vertical root fractures. Like I said, it's very hard to find those on regular x-rays. And there was a study that done back in 2009, and they found that the sensitivity and the specificity of using a CBCT were way higher than for radiograph. And that's why it might not be a bad option before you do the final call to refer the patient or to take a CBCT or a cone beam 3D scan and have the patient have this interpreted by an endodontist or by somebody who is well trained to read those, so you can make the final call. Again, it's not 100%. You're not going to be able to see everything in a CBCT, and you have to be honest and realistic about that when you recommend this type of diagnostic tool. Before also, like, there's one thing also that you need to know, that CBCT has limitation of how much you can see. If you have a post, if you have root canal filling material or gutta percha there, it's gonna create a lot of noise. You won't be able to see anything. And I will use an example right now to explain that. So this is an example from my office. Patient was presented to us. Patient had a root canal done on tooth number 12. I'm not sure about like the nomenclature system if you guys have in the UK, but basically it was an upper first premolar, and patient had an existing sinus tract, and he had this tooth root canaled many years ago, and then he had the root canal retreated for the same problem a year ago. It's still non-healing and it's still causing a problem. So we took a CBCT, and as you can see here in the CBCT, you see that there's a complete bone loss on the left side here on the buccal. Those are the probing in there. Same goes here as well, as you can see. But can you see a crack? Because I don't see. It's hardly to see one. You might like argue about this, but really it's not conclusive. So I explained to the patient that, you know, it's just the chances of this tooth to be saved might not be very high. The prognosis might not be favorable, but he wanted to do a loss reserve, so we decided to go for a surgical exposure. And here you go, loud and clear. Classic vertical root fracture on the buccal surface of the root, bone loss, and you can see it extended all the way. And that's when we confirmed the tooth cannot be saved, and the patient decided to go and get the extraction, but at least the patient wanted to go for the extra mile just to confirm that the tooth cannot be saved, and that's what we confirmed. Again, very hard to see those type of fractures on regular x-rays or even CBCT. This is an example, actually, this came last week in my office. This is tooth number 30 in American system, and also it's a lower right first molar. Tooth had a crack, and I would say like more of a split. You can see here I was able to put my Explorer in there. I caused wedging and it was moving. So I told the patient the tooth is split. I don't think this tooth can be saved. There is a periapical lucency. There is a deep probing. So the patient wanted to confirm that with a CBCT. We took a CBCT and voila. You can see here on the left side, you can see a clear crack or split going mesodistally. This is a view from the distal. You can see the crack extended all the way down, and severe bone loss around the distal root. And that's when we explained to the patient that tooth cannot be saved. Patient was in severe pain, so we went ahead and did the extraction. And you can see here clearly that the crack is constant with the CBCT. It's going all there. So the tooth was a gunner, absolutely no even doubt about that. Another example, this is a patient that came into our practice, tooth number 14, upper left first molar. Patient was having some symptoms on biting, was not sure what's going on. General dentist was not very sure about this. Brought the patient in, and actually, like, it was, as you can see, it's there's a clear crack on the occlusal surface. There was some wedging, and it's a virgin tooth. There's absolutely nothing. Look at the PA. You can hardly see anything on the PA. Patient actually, in this case, oh, can we try to save that tooth? I really want to save that tooth. I want to extract it. So before moving forward with that, we decided to take a CBCT. And in the CBCT, we can see it clearly. Clear split tooth. Going in there again, same mesodistally running, and you can see it's going on here in the distal. We explained to him, really at this point we cannot do much, even though it's a virgin tooth. Doing the root canal is not going to be an option. Why? Because you can't isolate that. It's going all the way. There's a furcation involvement here. At this point, the tooth has to be extracted. Patient was understanding, seeing everything, and went with a treatment option that we recommend. So in summary, I like to keep it short and sweet. If crack is suspected, you have to act ASAP. Do not leave things, do not monitor, because it's not gonna get better. One thing about cracks, they don't get better, they don't stop, they will grow in a way or another. You have to do something. Going from just a filling to a crown to a root canal really depends on location, extent, and how bad the situation is. If you have a question or concern, my advice to any general practitioner practicing that to reach out and to have a relationship with an endodontist in your area, in your community. Reach out to them. They're very well trained on diagnosing these problems. They have the ability to have the proper diagnostic tools, reading them, and help you achieving a proper treatment plan. So it's very important to go with that route and to have an endodontist that can help you to make the final decision about these kind of cases. But definitely, I wouldn't recommend leaving anything because it will only get worse. And that's it. This is my presentation. Thank you for your attention. And again, like I wanted to highlight a very important aspect here of the Cooperative Dental Society. I think it's a great idea. I think that many of us dentists should be involved in it and should be supporting it. I did that when in 2009. I went to a dental mission or a medical mission to Kenya in Africa, and I did that. Started like a dental clinic in a rural area. We did a lot of good things for people there. I know there's many ways and many aspects you can contribute to, but I think this is a good idea, and I really applaud the people who have actually started this idea. So go, show your support, and help this group because they're doing great things. And
Thank you.
Any question, I'm here to answer. So let's go for that.
Yeah, I can read them out to you, Tadros. Firstly, thank you so much for giving that talk. I'm sure we can all agree it was very useful. Got a few questions people put in the box. So one of them was about posts. So what are the type of posts that you'd recommend, custom made or fiber post? And also how far do you place it inside the canal?
So there has been many studies about that. If you custom made posts are not a bad option because they're usually short and they are usually like well fit in the tooth. But fiber post has shown some good overall or outcome. The only problem with the fiber post is that sometimes they put some stresses if they are placed in anterior teeth. So my recommendation is not to put them as far. Leave at least 6 to 8 fascia before going in there. I wouldn't extend a post beyond the the middle third of the root. And the recommendation is usually to leave at least a minimum of 6 millimeters of gutta percha at the apex before placing your post.
We've got another question here. Someone's asking, do you agree if the periapical lesion is beyond, I think, 5 millimeters, root canal treatment won't be successful or predictable?
Honestly, like 5 millimeters is not a problem at all. It depends on your diagnosis. It depends on why you have this 5 millimeter pocket. It could be just like a regular periodontal disease, or it could be associated with a crack or fracture, or it could be just a sinus tract. It really like depends on your diagnosis. Like I said, you can diagnose based on a probing, but you need to have a diagnosis to be able to treat things right. So existing probing, like I had a case that was almost like 10 millimeter pocket. We did the root canal and the bone forming there, and there was no pocket anymore. So it really depends on your pulpal and periodontal diagnosis.
Someone else asked but I think someone answered it in the chat. Is it methylene blue you said that you used to stain the cracks in the tooth?
Yes, methylene blue dye.
Yeah. Okay, cool. Yeah, if anyone else has any questions, you can either, you can unmute, ask yourself, or yeah, you can feel free to write it again. Give you like a minute to do that. But otherwise, if no one else has any other questions, just want to say thank you again, Dr. Tadros. And just before everyone goes, Maria, I'm going to pass it back to her. She's just going to talk a little bit more about sort of the charity project that we're doing. So I can hand that over to Mariam now if she wants to share her screen.
Okay, so I'm just going to be speaking a bit about our main aims as a charity. So CDS, we basically have two main aims. We have the charity side and the education side. So one of the main reasons we basically set up this charity was to raise money to provide dental care in Egypt. So as you can see on the slide, this is a dental van which we will use to provide this dental care to all people regardless of their faith in Upper Egypt. And we really want volunteers such as dentists and dental students. Sorry, I'm just gonna, can you guys see my slide?
Yeah, I can see it now. I think it wasn't working before.
Okay, perfect. So yeah, as you can see on the slide, this is the dental van that we are wanting to buy. And yeah, we want volunteers such as dentists, dental students from all around the world, and they can come and help provide aid. So this will be treatment, but it can also be just advice to patients for any dental students that are wanting to come and just see what is being done. And one of our aims is that it will be all year round. So anytime, whenever anyone has, a holiday off work or a holiday off uni, they can come and help and really help us people. So this will cost us about £50,000 or $65,000 to buy. And so far we've raised £15,000. So thank you so much to everyone who's donated already. And if you haven't, all donations honestly really will be appreciated. We want to be able to buy it as soon as possible. And anyone can donate on our GoFundMe page. So that has been already put in the chat, will be put in the chat again. And you can find it on all of our social media pages. For people donating from the UK, it's quite good because there'll be a tax return. However, in other countries, if you're trying to donate, there isn't this tax return. So if anyone from outside the UK would like to help with fundraising, maybe setting up a GoFundMe page in the other countries, just let us know. Again, on our social media platforms, which I've got over here. So Instagram, Facebook, and email. And just the other aim is dental education. So this will be through webinars. And if anyone's interested in giving a webinar, has a special interest or has any other ideas, just get in contact with us. We're always open to ideas. And yeah, our next webinar will be on the 17th of October, and the topic of this will be released shortly. But yeah, just watch out our social media pages. And again, thank you, Dr. Tadros, and thank you all of you guys for joining us. And I hope you have a good night.
I think someone had one more question, if Tadros is still there. It's about someone saying, usually treatment of a cracked tooth with pulpal or periapical symptoms is root canal. So when you access the cracked tooth, to which extent would you go ahead with the root canal? And then when would you decide to sort of extract the tooth?
So there is two ways of doing this. Depends on patient preferences, and after like laying all the options to the patient. What I always recommend is that if the crack is going beyond the orifice of the canal and extending into the canal, that's when you have to have this talk with the patient and give them options. If there is a perioprobing that is matching where the crack is heading inside the canal, then definitely extraction would be a recommendation, because if you have a deep probing and you have a crack extending into the canal, then your options are, it's very obvious that this crack is communicated with the outside and it's not going to be healed. But if you don't have a perioprobing, and if you don't have any periodontal involvement, and you do have a crack that's maybe starting into the canal, you have to tell the patient, okay, there is the options. We can do the root canal, knowing that we have a questionable prognosis. It may or may not work. And if it worked, here you go, you saved your tooth and everything will be fine. But if it will become symptomatic, then you're going to end up losing it. And I guess, like, when you put the information to the patient and you show them everything, that's when the patient can make a decision based on the information you provided. But for me personally, if I have a crack going into the canal and there is a periprobing, this fracture is communicating fracture, I will not proceed with that. But if the patient, but if you have the crack and you have no perioprobing, then you can always talk about options and possibilities and let the patient decide.
Thank you. Yes, I don't think there's any more questions, so we'll probably wrap it up there. But guys, as well, we've also, you'll find Tadros's sort of links to his Instagram and stuff on our page. So if you have any further questions you think of after, I'm sure he'll be happy to take those. And thank you once again, Tadros, for your time and giving us this excellent talk.
Thank you so much. Yeah, if you have any question, you can reach out to me on Instagram at Hudson Endo NH. I'm happy to answer any question. And if you have any cases that you wanted to discuss or ask opinion, I'm happy to help you with that. Thank you so much.
Thank you. Thanks, everyone. Good night.